Okay. And we're live. Hello. Today is our first edition of the Ask Dr. Beck podcast or show or whatever we're going to call it, brought to you by the Comella Foundation. My name is Bill Paravano, the knee pain guru, and we have the star of the show, Dr. Charlie Beck.
Good morning.
Hello, Charlie. Hello, Charlie. How you doing?
Good. Good.
We are, just so you know, we're broadcasting on YouTube and Facebook through the Comella Foundation channels. So that's what we're doing. We will encourage anyone who has a question to post their questions in the comment section. If you have a question, ask Dr. Beck. And we also have a couple of questions that have come in through the Comella Foundation website, so they can check that out as well. I figured this would be semi-informal, where I'm gonna have questions that are gonna come in either through the website, through the YouTube channel, through social media. And if we're running low on questions for whatever reason, that I'd love to pick your brain on the latest things that you're working on in your practice, cutting edge technologies and things that I know you push the envelope on. So really excited to dig into that. So welcome.
Great. What's the first question?
Okay. Well, we got to make it a little bit more interactive, Charlie. You know, this is needs to be slightly entertaining. So we're going to try to make it fun a little bit. Okay, we got two people watching right now. Let's see. Questions we got here. Okay, the first question is, here we go. So this was a blog post on the Comella Foundation website, the top 3 secret natural remedies for knee pain. The person writes, I am using knee supports, the cloth kind. The pain is in the tendon on the outside of the knee. I am also using Hempvana. Any suggestions? And I know it's a super vague question. However, how would you approach that, or what would you?
Okay, so that means we've got 2 things that we need to look at. The first is the brace. So we're using a cloth brace, no stays in it, and not neoprene. All right. That brace, in my mind, is there as a reminder only. It is really not going to do anything to change the mechanical forces coming into the knee or to prevent knee injuries. However, it's always there reminding your brain and your nervous system, we have an injury in the knee, we need to be careful with it. So as long as we understand that knee brace is not bad, it's just not going to prevent further damage.
Okay.
All right. So then in the lateral aspect of the knee, we have the lateral collateral ligament that attaches the fibula to the femur.
Okay.
So if you got any questions about that, want a picture, you can look it up on the internet. Lateral collateral, collateral ligament. It'll show you a picture of where it's at.
Okay.
So that ligament can be damaged, but it's more common that because it's attached to the fibula, there's something going on in the foot that's dragging on the fibula, dragging it down toward the foot, causing that ligament to be under pressure. And if you fix what's going on in the foot, and most often it's a cuboid bone that's restricted, then you fix the knee. Okay?
Gotcha.
If you do that, you don't need the supplements.
Okay. Gotcha. I'm following what you're saying. So you're if I understand you correctly, the knee isn't so much of the issue as the tension pattern that is originating in the foot that is pulling the fibula towards the foot that is causing the issue on the outside of the knee.
That'd be correct.
Okay, cool. Any other tips or suggestions that the individual can do, the gentleman can do? Let's see. We support. This is. Oh, I'm sorry. This is Paula.
There's all kinds of things that I would check for in my office. So what comes to my mind is find somebody in your area who's knowledgeable about the knee, go see them, if nothing else, to get an education on how it works. And then you can be educated so that if this problem ever comes up again, you either know that you can address it yourself or that you need to go see the person you went to see before.
Okay, we just got some feedback from some of our viewers. One was around the fibula. Being that this is the springy bone on the outside of the lower part of the leg.
Correct. The tibia is the shin bone. It's the one in front. It's the one you kick chairs with. And the fibula is the bone on the outside, on the pinky toe side of the leg.
No matter which leg you choose.
No matter which leg you choose, it's on the pinky toe side.
Okay. Got it. Thank you, Christina. Okay, let's see. And to be able to submit your question, I'm gonna get that website URL up there in just a moment. But let's is there anything else you wanted to share with Paula regarding the that tendon on the outside of the knee? The knee support thing?
Yeah, so there's one more piece, and that is where the pain is. So that tendon, the lateral collateral ligament, has some thickness to it. It's got some anterior posterior depth. So it's big as let's say your thumb from front to back. And if you push on the front and it's sore, it tells us one thing. If you push on the back and it's sore, it tells us another. If it's sore all the way across, it tells us a third thing. And that's just information to share with the person that you go see about educating you about what's going on with your knee.
That sounds awesome. I was getting some of the I was getting that together so people can actually go to the this will be moving forward, we'll have a dedicated web page where they could submit their questions for the show, whatever they have going on. And Charlie, maybe let's go into details on what is going to make your response different from another doctor out there.
I'm going to give you this Alex answer first. Goodness, I don't talk to the other doctors. I have no idea.
Yeah, well, there's that.
But so being an osteopath, and I would say being an osteopath who does osteopathic manipulation, we look at the body differently than almost all of the other healthcare professions. I want to know mechanically what's going on with the body. And most of the time, and I'm going to say above 95% of the time, if something is not moving correctly, it's painful. If you restore normal motion, the pain goes away. So that's the piece that I'm looking for that many other doctors don't. They want to, because of the way they're taught, give you surgery, give you physical therapy, give you a pill or a shot. And they don't look at the mechanics. And so I tell people this is like if you crash the front quarter panel of your car and you take it to the body shop, you want somebody who's going to fix the quarter panel, not paint over whatever's there and give it back to you. And that's often the way I see what the other doctors are attempting to do if they don't look at the mechanics of the knee.
Mm-hmm. Gotcha. Okay. Thank you, sir. Next
Absolutely.
question. Glenn writes, felt much less tension and pain. I overworked my back muscles for about 2 weeks. It was bad, and the simple exercise works great. So this was actually a positional release for the psoas. So it was putting pillows underneath their knees for 30 seconds and get up and try it and see how it feels. This is what Glenn was commenting on. This was on the Comella Foundation website, one of the blog posts.
Yep.
So the title of the blog post was the #1 simplest exercise for lower back pain.
Gotcha.
Keeping it real simple. Let's see.
Now, if you said 30 seconds, I would say make it longer. Make it
a
minute and a half to 2 minutes, which simply gives the muscle more time to relax.
Right. Absolutely.
And then I would add, because the psoas is actually two muscles, it's the iliacus muscle and it's the psoas muscle.
Okay.
You can relax the psoas by doing what you're doing. You can modify it to relax the iliacus muscle. And all of my anatomy models are at the office, so I'm going to use my hands. If we look at the pelvis from the front toward the back, then the pelvis is kind of shaped like this with the sacrum where my thumbs are, right? So the front of your body is pinky side.
Right.
If I take my finger on the outside of my body and I try to come along the pinky side, let me get this in front of the camera, the pinky side of the pelvis, and I hit pain right there. The iliacus muscle hangs out in this area. That's its place. So if that iliacus muscle is tight, it's part of the psoas. Okay, so you're basically, by doing the psoas, you're addressing half of the issue and not all of it. If you take your legs, which are up on the towel, and you move your legs in or out until you feel the motion occur right where your finger is on that iliacus muscle, and now wait your 90 seconds or 2 minutes, you got both.
Iliacus and the psoas.
Correct.
Got it.
Well, you're doing the iliacus portion, but you've already done the psoas portion with what you described earlier.
Right. And when you're talking about moving your legs in or out, are you just moving the knees or are you moving the feet?
If you're up on pillows, it's probably going to be easier to keep the feet together and move the knees. Technically, you can do either, but you don't want it to fall off the pillow or towel or whatever stack of stuff you have supporting it. Sure.
And for the question was just there. For those curious about these muscles, think of it in the center of your belly. Center of your belly, like in your right on the inside of your spine. Would that be?
That's pretty good.
Close enough. Well, so we can get real anatomically correct, and we can also say if it's comfortable and it relieves the tension in your back, you're doing it correctly.
You're doing it correct, exactly. If it works, you're doing it correctly.
If it works, you're doing it correctly. And we have a few more people that have popped in. If you have questions to ask Dr. Beck, he's a osteopath specialized in manual manipulation. We have an incredible wealth of knowledge that we are all very fortunate to have access to on YouTube today. We're going to be doing these every Wednesday through the Comella Foundation. Comella Foundation is a nonprofit 501c3, and we're committed to helping people relieve pain. So, okay, so that was with the lower back. We have another question from Ellie. This was regarding the same video or the same blog post. You're supposed to lay on the floor with your calves on the couch. I believe I might have demonstrated this with your legs up on the seat of a couch as well.
Yes.
Is the angle is the angle of the legs, the lower part of the legs, going to change whether we're addressing the psoas or the iliacus when you put the legs up on a couch?
No.
And would there be an indication why someone would want to put their legs up on a couch as opposed to pillows, other than they have a couch and they don't have pillows?
Yeah, one's easier than the other. That's all that matters.
One's easier than the other. Okay.
So,
So
your question is, I'm going to say no, the angle of the lower legs doesn't matter. And let me see if I can figure out how to do this. All right. So if we're using, oh goodness, how about this? Let's just say that, okay, so we've got, got to figure out how to do this on the camera. That's the lower, that's the calf, sorry, the thigh.
Okay.
And this is the calf.
Right.
This angle doesn't matter. This angle matters. So moving your legs closer in or further away from you changes the point in the body that we're working.
Okay.
Okay. So basically that is moving your butt closer to the couch or further away.
Okay.
Legs stay up on the couch. I'm
Yes.
either going to slide my butt closer to the couch or further away. And this can be, I mean, I get precise about it, but you don't have to be. This can be a trial and error. You put your butt in one place, legs up on the couch. You sit there for a minute and a half, 2 minutes, and you test it. And if it didn't work, you move your butt somewhere else and try it again.
Right. And this gets in what you just suggested. If it doesn't work, you change the angle and you try it again. And I think this is where we get into the psychology of pain, is that many people, if it doesn't work, well, it doesn't work. And I got to go restart over somewhere else, doing something else. I need to do exercises or something like that. And I think this is a point what Dr. Beck just shared is really the source of how people can really get rid of pain. Is that instead of going wider with many techniques and many different modalities and things like that, we take what we're working with and go deeper and do the nuance thing to figure out what is the position of comfort that is going to make the biggest difference for the lower back pain in that moment.
And maybe a good analogy here would be fishing.
Okay.
So if I take my fishing rod and I place a worm on the end of the fishing rod and I put a bobber on it and I cast it into the water, I expect, this is the very nice thing, that I get a fish. And in theory, what we're doing here is we're saying, oh, within a minute or two. But that isn't reality. Because if you're fishing the right place and the fish are hungry and you have the right bait, you might get a fish. But if any of those variables is wrong, you have to figure out what the variable is, fix the variable, and continue doing it until you achieve success.
Right. Yep. Okay, we got a question that came in from YouTube. Many in my family have had knee replacements. They all have knees that kind of turn in like their legs aren't completely straight, and they have pronation in the feet. They are related, right?
The family members are related. I would say that's correct.
Yes, I'm going to be. Unless we start doing DNA tests. Just to double check.
Okay. So just to be clear, if we're talking about the folks with knee replacements, the mechanics work a little differently than if we're talking about the folks without knee replacements. Okay. So in a knee replacement, we've got the femur, the upper leg bone. It makes up the top part of the knee. And the tibia, the lower bone, makes up the lower part of the knee. The kneecap sits in front, and the femur sits on the the fibula sits on the outside. We talked about before. That's the bone on the pinky toe side. When you do a knee replacement, you pretty much take a Sawzall You move the knee cap left or right, and you literally saw off the knee. Okay. And then you take a metal piece, you drive it into the leg on one side, you drive it into the leg on the other. And yeah, I'm watching your response. This is actually what happens in the operating room.
I know. I've seen YouTube videos. Anybody doubting what Dr. Beck is saying, do a Google search, do a YouTube search on knee replacement surgery. And you'll know what I'm talking about.
What's happening on the other side is it's all supposed to work together. Okay. So I absolutely admire orthopedic surgeons. They do a wonderful job. Based upon what I see in my practice, I think every orthopedic surgeon should start out as a carpenter so that they understand that a 32nd of an inch makes a difference. And what happens is they try to get the leg they're operating on to be the same length as the other leg, but they don't always. And so when the other leg is off even a tiny bit, it can change the posture of the person and the way the feet interact with the ground. Okay, so it's a variable that once the surgery's done, it's pretty hard to change. Better to find a really skilled surgeon and get it as close to right at the first time as you can. Okay, so pronation of the feet. So in medical terminology, what we have is supination. This is a Latin term. And the way that we learned it is literally you think about holding a soup bowl. Okay. This is supination. Turning the hand over is pronation. So in pronating the feet, what you're doing is you're pushing the big toe side of the foot down toward the ground. Okay. Collapsed arch is a way of thinking about it. Does that change the way the knees work? Absolutely. Like in every patient on the planet, it would change the way the knees work. The knees are a balance between the inside and the outside. And in theory, your foot is balanced so that its force comes up through the center of the shin bone, tibia. So when you stand, the force comes up through the center, through the kneecap, and that's the way the knee is designed in you to work. If I pronate, I shift the force. And because I'm shifting the force to the inside at the bottom, it goes to the outside at the top.
So this is going to bind at where the fibula and the femur meet? Am I understanding that correctly?
Tibia, fibula, and femur. Yes.
Tibia, fibula. Okay. It's all kind of jamming together on the outside of the knee.
Correct. And that's assuming that you don't compensate. Some people will compensate and their brain drives the pressure to the outside of the foot because the inside of the foot is no longer stable.
Okay.
Which then will give you the opposite effect.
So you'll have issues on the inside of the knee, or it'll push the tension to the inside
Correct.
of the knee because the major compensation is taking place in the foot instead of it's still ending up in the knee too. So
but it's not balanced in the knee.
Right.
If we look at it from the tensegrity structure that we talked about when we last met, the tensegrity structure is now out of balance. And so then what happens is the knee is no longer self-supporting, and you're getting one cartilage pad, either the inside or the outside, that's getting more wear than the other. And so now if we do something about that in the first, let's say, year or so, not a big deal. You're going to go back to normal. But if we don't know about it and it happens and it's now years from when it started, now the wear and tear is such that you're going to have to either reestablish the tensegrity system and do something to rebuild the cartilage, or consider having it replaced.
Got it. I think one of the questions, the way Christina asked a question was around if it's a generational kind of pattern that could be showing up in the feet that is resulting in the knee replacements. That might be.
So then here's the question that you're asking. When I was created inside of mom, there's a gene that separates the cartilage from the inside and the outside of the leg, right? And at least the way that we were taught, no, there's no gene that does that. The cartilage that's laid down is either good cartilage or you have a genetic defect, and the cartilage over every place in the body is not good. Okay, so genetic, I would say, maybe not. Familial, maybe so, because the way your feet work also depend not only on a mechanically working foot, but the footwear that you place on your feet.
Mm-hmm.
And so if, let's say, grandma grew up with a certain belief system about how shoes should fit and what shoes you should buy, and passed that to mom, who passed it to daughter, and none of them are mechanically right for the feet, over time, you wind up with the same patterns in the knees.
Got it. Okay, let's see. Dr. Beck. If you have questions, we have a few people online. If you have questions, please enter those in the comments. We are on streaming live on YouTube and Facebook. We have one more question that came in through the Comella Foundation website. It's from Dagmar. I am not an athlete, 72 years young, with shoulder stiffness and pain and limited range of motion of arms after years of working long hours on the computer without stretching. Being a mindfulness and meditation teacher and educator, I love how that you have connected breath with the exercises and would love to see some shoulder exercises to release and lengthen muscles. So do you have anything on shoulders that you could share? Insight, understanding, perspective?
Lots. Let's see. The first thing is, mechanically, I have met few people who actually seem to understand how the shoulder is supposed to work.
Mm-hmm.
So, for example, finding a physical therapist who can really get good and lasting results in the shoulder, they're out there, but they're few.
Mm-hmm.
It most of the time even stretches into the osteopathic community.
Mm-hmm.
So here is what I've found. First of all, we have to understand anatomy. The shoulder is made up of the head of the humerus, that's the upper arm bone, and the glenoid fossa. And fossa in Latin means depression. That's all. So if we were somehow able to lop the arm off, let's see here, we lop it off here, there's a scoop, it goes the other way, there's a scoop on the shoulder, and then the head of the humerus sits inside the scoop, okay? And the way we learn it when you're looking at an x-ray, it looks like a scoop of ice cream in an ice cream cone, okay? That means that it has not dislocated, but it doesn't mean that it moves. So what's supposed to happen, and let me see if I can do this in front of the camera. We've got glenoid fossa, it's our depression. We've got the head of the humerus, and it's supposed to sit in the middle, okay? So it's supposed to do this. It's supposed to then be able to move up and down, supposed to be able to move forward and backward, supposed to be able to rotate, and then it's supposed to be in 3 dimensions. That shoulder is supposed to move.
Mm-hmm.
What I have found in my patients is that very commonly when we have shoulder stiffness, let me see how this. All right. So I'm going to make thumb side the front of the body. So the humerus in relationship to the shoulder moves forward. rotates. And so technically it's not outside the joint, but it doesn't move well. And so what you've got to be able to do is get that the actual arm range of motion all goes away. It's finding someone to do that. That's the challenge.
Yeah. Is it more a function of raising the bridge or lowering the river? Do we need to relax the tension in the front, or is it more about getting the things in the back to engage?
It's a hard one for me because we always approach it from the balance side. So the real answer to your question is yes, we've got to relax the front, get the back to come back to normal tension, and then it moves back to where it's supposed to.
Right.
Now, from a palpation standpoint, the front is most often what is super duper tight.
Yep.
So it's the front pulling rather than the back pushing.
Right. Yeah, it was interesting. The understanding of the shoulder I got from Systema in punching, and this was crazy. So Vlad was talking about extending the arm without tension. Well, we can't extend the arm without tension, which is a punch. It's just the extension of the elbow. You can't extend the arm without tension if the chest, the shoulder, and the bicep is engaged with everything pulling forward. So we had to begin to learn how to engage the scapula, bringing the scapula in and down, which disengages all of this in the front and allows the arm to be extended without tension.
Got it.
It's exactly what you're talking about. Like, you got to relax the tension, and the Russian martial art approach was a little different.
I would add in that there's one other thing that I have found recently, and that is that there is a dental connection between the back molars, and specifically the upper back molars, and the shoulders.
Okay, tell me.
So let's just say, for example, you get your teeth cleaned, and the person cleaning your teeth uses one of the dental picks and pulls a little more than they should on one of your back molars, trying to get some plaque off. Okay, they're doing their job.
Right.
Your body's response is to tighten the palatine bone, which is the bone that sits in the very, very back of the top of the mouth. So it's kind of where your soft palate is.
Okay.
And when that palatine bone gets tight, the shoulders respond by getting tight and then pulling forward. So I don't know if you can see it here.
Yeah.
Let's see, figure out how to do this in the camera. They come forward like this.
Yep.
Okay. And that's stuck in the mouth. So I have found, and this is something that my wife and I figured out, I've found that if you release the mouth, the shoulders drop back and they're good to go.
Wow. And are you releasing it through the teeth? Or are you releasing it in the palatine bone that you were talking about? Or what is the...
Yes. I use the teeth for handles to get to the palatine bone.
Wow. Okay. Cool. See, everybody, this is the kind of stuff we got to begin drawing out of Dr. Beck, because the connections that he's aware of and noticing is just, it's fascinating to me. And I think for many people who are stuck going, okay, well, I've been going to physical therapy for 3 months and nothing has changed, or I've gotten 10% better. This is the perspective that's a game changer in the physical body. When you begin to release these patterns that are stuck, now you're not fighting your body body to allow it to heal. Your body wants to do the healing. So, okay. Anything else you want to share? Anything's popping into your head before we kind of wrap it up here? I figure we keep these in and around a half an hour ish.
Yeah, I'm good. You've tapped my brain today.
Okay. So just to let everybody know what we're working on at the Comella Foundation, we have the Ask Dr. Beck link. There are more links below. One is a pain relief portal that we've put together where we're having, if you're having an issue with pain, back pain, neck pain, shoulder pain, we have a service we have a woman out of Pittsburgh, Pennsylvania, Jeannie Anderson, that is doing remote muscle testing. So you will put in your information. That will go to her. She will send you the link from the pain education podcast of the person that I've interviewed in the podcast that would be able to help the most. In addition, we have the pain relief portal. We have the pain education podcast. We have the Ask Dr. Beck show hour every Wednesday at 7:30 a.m. Eastern time. We're going to work with this time for now to see how that works. And all of that information is in the description box below. So that's what we got, Charlie.
Cool. Well, thank you, Bill.
Thank you so much. Thank you so much for being here, and we'll chat with you soon.
Sounds good. I'll see you next week.
Thank you. Bye-bye.